Next speaker is Dr. Muna Bende. She is a director at Shankar Netralaya, Chennai, and excellent clinician and teacher to many of us. So she will be speaking to us on predicting progression of dry age-related macular degeneration and its significance.
Good morning, everyone, and thank you, Neet, for inviting me. I think this is probably the only talk of the session which is based on retrospective studies, and it's only something that is planning for the future. The natural history of geographic atrophy progression, most studies give it over a period of 4 years. And they show that there is a change in lesion size, but it basically depends on the number of lesions, the shape of the lesions, and their location with respect to the fovea. So atrophic lesions with a diffuse, linear, or banded autofluorescence pattern seem to grow more rapidly. So if you look at this picture, when they show various patterns of autofluorescence and look over a 2-year period, you find that cases with banded autofluorescence, cases with diffuse or trickling autofluorescence tended to grow more than areas with no or only focal autofluorescence abnormality. And then we also have a factor that says that the growth is strongly related to the lesion perimeter. So you have the same area, but you have a round lesion and you have an irregular lesion, and the irregular lesion grows more. So if you look at this little graph shows it very nicely. And this is one of my own patients with an irregularly shaped area of geographic atrophy. You look carefully, the advantage of your autofluorescence is that you see the entire lesion en face. And you see these slight, subtle changes here. You see this little tail growing here over a 1-year period. You see a little bit of increase here. So this is the benefit of autofluorescence imaging when you do when you're looking at progression of geographic atrophy. So there are other precursors and that are related with the development of geographic atrophy, and basically minimum change autofluorescence tends to progress more. And this is an interesting graph that shows that at the start of the study, when there was very little autofluorescence changes, you see how many of them progress to atrophy at the end of the study period. And these, again, like I mentioned, most studies are retrospective, looking at the end point. This is the final visit, and here you see this irregular shaped lesion, this multifocal lesion, is growing more than the unifocal lesion. This is again my patient. Here you see, you decide this is the fellow eye of the patient. You see this small area of geographic atrophy. You see this little tail increasing. There is surrounding area of hyper autofluorescence. And you see that over a 1-year period, it increases more. And then this is just a few months later when the patient said, my vision is getting worse. I did the autofluorescence imaging. It looks the same. He basically had developed PCO pacification. He was pseudophakic. So, yeah. So what are the precursors? Most of these studies give you a time frame of 4 years. I don't know whether it's coincidence, but a lot of my patients also have seen progression at 4 years. So what are the earliest changes? Early local photoreceptor changes and drusen accumulation. These are the highest risk of progression to geographic atrophy at the end of 4 years. And they precede other anatomical heralds such as RP changes and changes in the drusen substructure. Again, this is the CAM study. A lot of talk has gone on about it. In India, we see very little of geographic atrophy, so for us, maybe a little theoretical. But yes, they have identified certain features that are at risk for atrophy development, like hyperreflective foci, drusen, and subretinal drusenoid deposits, formerly known as reticular pseudodrusen. This is a very interesting review article that I found, which aimed at evaluating the status of OCT biomarkers for prediction from intermediate to advanced AMD. And they looked at all these various factors. Most of it were changes in the outer retinal layer, seeing the continuity of the external limiting membrane, disruption and thickening of the retinal pigment epithelium, changes under the drusen hyporeflectivity. Here you see difference in character of the drusen from homogeneous to heterogeneous, and these are features of reticular pseudodrusen or subretinal drusenoid deposits, which currently are believed to be at the highest risk for geographic atrophy development. And these were the various parameters they looked at, and they found that the predictors of conversion to atrophy, the highest was drusen collapse. And I'll show you some of my own patients where drusen collapse was seen. Now, when I said we need to look carefully, sometimes you need to use these multiple line scans to look for individual areas of change. Right now, more of theoretical, but if you look at all these subretinal deposits, you see one that is looking a little different. There is some hypertransmission, and there is some amount of deposit above the lesion. And you see a few months down the line, this is about 1 year down the line, you see this area has collapsed. There's collapse of the outer nuclear layer. So you would need to definitely look at these images very carefully to see how things progress. And this is another patient. You see this is 2018. You look at this drusen. In 2019, you see now that there is this small hyperreflective dot. Why is it important? It's because it's close to the fovea. This is not a sign of progression to neovascular AMD. This is a sign of progression of geographic atrophy. Sometimes you see the drusenoid pigment epithelial detachments. You see this patient 2017, 2018. So it's 2018 and suddenly came in 2019. You had an enlargement of the drusenoid PD and then suddenly it collapsed. So an increase in size of the drusenoid PD suddenly does indicate that this is going to be collapse at some time or the other. And this is another interesting feature called drusen ooze, which is a novel hypothesis in geographic atrophy. Why is it important? It's because we can sometimes mistake it for neovascular AMD. This is a patient with a small drusen, and you see after some time the change in character and the lesion collapses, giving rise to atrophy. Now, identification of an acquired vitelliform lesion, this is part of non-neovascular AMD, and it's important because it can very often be mistaken for neovascular AMD, the reason being the presence of subretinal fluid and this area of RP thickening. This is one of my own patients, and this highlights the importance of OCT angiography imaging. You see this vitelliform lesion at the fovea. The OCT angiogram shows no neovascularization, and you see later this lesion has collapsed without treatment. Now, this is a lady who's 90 years old, and I've been following her up for many years. She has dense asteroids and vision of 6/6 with advanced glaucoma in both eyes. And you see how her drusenoid PD increased in size. She has a little irregularity of the surface here. This is the fellow eye. Again, you see the drusenoid PD increasing in size. Now, with swept source, we are able to see the content of the drusen, content of the PD. Suddenly, one day, this PD increased in size, and the next visit, it had collapsed. But if you look carefully, the outer retinal layers are intact, which is why she still enjoys 6/6 vision, but with a tubular field. So sometimes drusenoid PDs collapse without causing much of a visual loss because the outer layers are intact. This is her other eye. The lesion is increasing in size. There's some changes on the summit of the lesion right now, and I would expect probably her next visit, this lesion would have collapsed as well. So this is an interesting reference which says that RP death is linked to the lifestyle of drusenoid pigment epithelial detachments, and it's heralded by a sudden increase in size and then collapse of the lesion. And this is exactly what we saw in our patient. This is a slightly younger lady, and she had these large serous pigment epithelial detachments at the fovea. You see some pigmentary changes at the summit. And this is what we need to watch for, this cap of subretinal fluid on the surface. This is part of the drusen ooze hypothesis. This is not a sign of neovascular AMD. She developed it in both eyes. And this was the picture. You see the autofluorescence changes more obvious in the left eye, and the next visit the lesion had collapsed. This is a subsequent visit, and then finally this is the last visit when she saw me a few months ago, when we see that the PD in the other eye has also collapsed. This is heralded by the leakage or the ooze of drusenoid material into the periphery, leading to the lesion collapsing down. And this is her fellow eye. And This is probably the longest follow-up of one of my patients from the year 2007 to the year 2019. You see this lesion in evolution, and what happens during each process is these little discontinuities on the summit of the PED with areas of subretinal fluid. At each time these close, the lesion collapses, there is a change in the content of the drusenoid PED. And finally, here you see that much better, these multiple little gaps in the pigment epithelial detachment. Finally, from 2019, the lesion is now flat. His vision is poor because he has outer retinal atrophy as well. This is both eyes of a patient with non-neovascular AMD. You see pigment epithelial detachments with pigment proliferation on the surface. This irregularity or thickening of the RP should not be mistaken for CNVM. And this is the fellow eye where you have a little nodular changes on the surface with hypertransmission as well. If you look at the progress of this lesion, you see that the patient had developed small areas of atrophy on the summit and overlying areas of cystoid macular edema. And this was actually retinal pigment epithelial aperture, which is one of the stages in evolution of dry AMD and not related to choroidal neovascular membrane formation. And these are two references on that. And this was the left eye with multiple apertures, eventually went on to atrophy. For the right eye, just a moment of caution. When we get so excited about atrophic AMD, we may sometimes forget there are biomarkers for neovascular AMD in the same eye. This is the same patient. You see the right eye, as the lesion flattened, you see some changes nasal to the lesion here, some amount of hyporeflectivity under the drusenoid PD that eventually, over a period of time, you see this lesion as you follow it. Oh, I'm sorry, I'm missing a slide. You see this lesion after some time developed a small neovascular membrane. So as the lesion flattens, there is sometimes the occasion of conversion to neovascular AMD at the borders. Yeah, and this is what was the end point. Patient had a large choroidal neovascular membrane. Outer retinal tubulations are other biomarkers for atrophy. They're at the border of the atrophy. They may be protective in terms of neovascularization, but areas of outer retinal tubulation are believed to limit the areas of atrophy, as you see in this beautiful slide from this demonstration. And we cannot leave OCTA far behind. Areas of choriocapillaries flow deficit are believed to be early biomarkers for geographic atrophy development. So this is my last slide, and I would put this as a disclaimer. The current relevance is mainly planning of protocols and endpoints for clinical trials, because we have such good imaging now that we are able to see this. We have data for many years in retrospect. So these are the main precursors for progression of atrophic AMD, something we are likely to hear more about in the future. Thank you so much for your patient listening.
Thank you, ma'am, for that wonderful talk. Do you have any questions, please? Yes, please.
So the follow-ups? Yeah, I was seeing her about 4 to 6 months with an AMSLR. She's 94 right now, so it's difficult to get her in, but well educated and able to follow up with the AMSLR. When the drusen PED increased, actually she had gone to see someone else who suggested an injection. She got worried and came and saw me, and then the next visit the whole thing flattened. But 4 to 6 months with an AMSLR should be fine.
Good morning, ma'am. Good morning, panel. So the question is, when we are trying to predict the recovery rate for these diseases, there are patients who are lined up for the cataract and they already have these diseases, and the patient doesn't want a cataract surgery or he doesn't want a macular surgery. So for example, in a GA patient or in a ERM patient, he says, don't do my retina treatment, just give me a cataract surgery. And he's insistent on that. But then we have to follow him whether he is progressing or he is stable. That is one part. And after cataract surgery, we need to redo the whole investigation and check whether he has progressed. So I just need a comment on that.
I think probably we tend to use PAM, and that gives a fairly good prediction. Cataract surgery is not a contraindication, definitely, even if the patient has geographic atrophy, and especially if they have poor vision and a dense cataract, it will definitely improve the quality of vision.
Yeah.
So as long as we tell them that, then I think they're okay with it.
And
But we
maybe,
can't promise them perfection.
Right.
And if cataract evolves during the course of your follow-up, then it's easier to convince them. It's the first visits that's the problem.
So maybe for in a case of ERM, maybe we can do a surgery and we repeat the test and show him the biomarkers.
Yeah, no,
Tell him.
basically for ERM and macular holes, I mean, it's slightly different. The indication for surgery for macular hole, if it's there, you are advising surgery. If the patient doesn't want, then you are doing a suboptimal treatment, whatever it is. Then everything after that is makeshift. Okay.
Correct.
Now coming to ERM. So ERM is one condition in which you have, let's say, a 6/9 or a 6/12 ERM with a cataract. I have advised cataract surgery for some people, and I assess the vision after that, and I offer ERM surgery unless it is very heavily distorted. If it's just a 4-wheel elevation, a 4-wheel straightening, it's just an option. I'm not saying that. I mean, ideally you should treat the macular condition. The concept of treating the macular condition, the concept of the cataract surgery are two different that get integrated at some point of time. Okay, George.
I just comment on that. Many times people have OCT as part of their pre-op package when they're planning a premium IOL. And that's when the confusion sometimes starts. You see a little bit of thickening. Patient really doesn't have much problem as far as the vision is concerned. So if it is just a finding on the OCT and clinically you feel that it's really not that significant, you cannot, probably would be cautious about saying I'll do a multifocal. But otherwise I think it's okay to wait because many of them are quite happy with the vision after cataract surgery.
Yeah, phasing in 2 phases. First, it would be a good option, I also feel. I have a comment on that beautiful case where the drusenoid PED had subretinal fluid, and do you consider at that time any OCT angiogram? I mean, do you consider a subclinical CNV in drusenoid PEDs when you see a subretinal fluid, like for the audience? Do you or just observe these? Thinking that this is the transudation from the RPE defects that you see?
I'd probably be looking more at an OCT angiogram if I'm seeing the fluid at the sides of the lesion rather than on the summit. And if the fluid is associated with just some pigment, it's a small gap of fluid at the summit of the PED, then I may not do an OCT angio. And when you have these highly elevated lesions, you also have to keep in mind the segmentation artifact that will come, because then, very often it may be mistaken for a CNVM. So
why
would
I
be
ask
cautious
is, even
about
we
that.
have seen some of these, not at the apex, proper subretinal fluid in the presence of drusenoid PEDs, and ICG angiography do not show any neovascularization. Even Octa, as you said, the segmentation problems and doesn't show any thing. So probably we observed the patient because we didn't get anything on ICG angiography. So that
probably the most important area, like the acquired vitelliform lesions, those are the ones when definitely we would recommend to investigate more.